have retold the field. Because the retold.
Sir, me the unmute ains. Okay, that's fine. Yeah. So basically, if you want to get a basic idea of what liquid ventilation is and how it is applicable, the right side one video article. So request all the participants to please kindly mute your phones or laptops or whatever you're using, and also be aware that you are sometimes pressing the unmute button again. Yeah, thank you. So this this article in the Oman Medical Journal in 2011. So about this liquid ventilation, though he has pressed more on partial liquid ventilation, which is actually currently the ready mode in liquid ventilation. So this has beautifully summarized all the implications and how it is done and everything. That's a review article there. I will send all the articles in our group later. So so this liquid ventilation concept is not new. So you will be actually surprised how I came across this one. So I was reading one of the Dan Brown novels. So at least some of you might be knowing, he writes some thriller sort of novels. So in that, in a scene, he wrote this. Actually, the con person will immerse him in the liquid and create a feeling that he's being drowned in the liquid to the hero. So he feels that he's getting drowned and short of breath and all, and then he reveals the secret to the villain. So later, when the police reach the place after a few hours like that, they see actually he is alive. So then he explains this concept of liquid ventilation with perfluorocarbons. So this almost like dates back to some few 20-25 years back. The novel was written, and in that novel he has mentioned about this liquid ventilation. Then I did the research and all, spoke to Kavita madam and all. So, and that's how I came across this concept of liquid ventilation. So what is this liquid ventilation? So normally we do the gas exchange. So instead of gas exchange, they select a carrier to carry the oxygen and remove the carbon dioxide. So when you choose an ideal agent, so the ideal agent for carrying on. So it's Ravi and Gazwak Ravi Kumar sir. Okay, whoever Ravi, frequently your microphone is getting on. Please take care of that. Yeah. So what is the ideal agent for carrying the oxygen and removing the carbon dioxide? So it should have a high solubility and a greater density than body fluids, so that it descends to the dependent portion. Most of the times we follow this alternate types of ventilation in traumatic lung conditions. It can be pathological or traumatic. We generally tends to increase the basal parts or the most affected ones in this. So it should have a high density so that it descends to the dependent regions of the lungs and reopens the area. And it should have a low surface tension, so to work like a surfactant and improve the lung compliance. And it should be inert and not metabolized and should be eliminated by evaporation or the transpiration through the skin. So it should have a sufficient volatility to allow the elimination in an acceptable time. So these are the ideal transporting agents for the carrying in the oxygen and removing out the carbon dioxide. So when they found out, so only two particles or some like only two have met all these criteria. So one is perfluorocarbon and the second one is the silicon oils. So silicon oils are highly toxic to the human body or whatever even to the experimental animals. So the only option left is perfluorocarbon. So perfluorocarbon is a type of synthetic liquidinated fluorinated hydrocarbon. So where a hydrogen ion is replaced by a fluorine atom, and also there is a bromine atom added to it. So these are chemically and biologically inert. They are not eliminated by kidney or liver, and they are actually having a low surface tension, and the oxygen carrying capacity is more than 3 times that of blood for the perfluorocarbons. And the carbon dioxide elimination capacity is 4 times compared to the oxygen carrying capacity of the perfluorocarbons. So because these are actually dense fluids and they have a high coefficient gradient, so these has to be driven by a machine. So you cannot normally do that. So how they did that in the early past? Actually, this concept of liquid ventilation is being in study since 1962. That dates back to 60 years earlier. So when the early in the pathological lung conditions where the surface tension increases, so then the thought of lowering the surface tension, that is how the synthetic surfactant we use actually helps. So this is the same way. Perfluorocarbons have the low surface tension, and introducing the perfluorocarbons may actually decrease the surface tension and help in the gaseous exchange better. So again, when it comes to liquid ventilation, there are two ventilations: partial liquid ventilation and total liquid ventilation. So what is the difference? So where the partial liquid ventilation, you fill to an extent like below the residual volume, the perfluorocarbons, you first inject them, and over that you do a gaseous exchange with a normal conventional ventilator. That is partial liquid ventilation, and there are several human trials also with partial liquid ventilation. So then comes the total liquid ventilation. So the total liquid ventilation where the even the residual volume and also the tidal volume in and out is completely through the specialized liquid ventilators. So there the conventional ventilator doesn't work, and you have to do it with a specialized liquid ventilator. So how they do it? So there are 3 ways which are studied over a period of all these 50 to 60 years. So in earlier days, they used to have like a machine above to inject this liquid into the lungs through gravity dependent, and there is a collecting one below the patient or baby. Actually, these human trials are also, most of the human trials are conducted in the preterm infants and near death respiratory distress infants. All these are the ideal criteria for the human trials, because anyhow they are dying, so they have tried out this partial liquid ventilation in those babies. Actually, initially most of the studies were done in them, and obviously animals. So another way of getting in through liquid is through a side port from the endotracheal tube, and the third one is directly tracheal installation of the perfluorocarbons. So it's generally done. They say the best way to inject the perfluorocarbons is through rotation. So you alternate the position between supine and prone during the incremental dosing. So now again, why this again, when with partial liquid ventilation, you're like most of the studies also showed a near success rate, they work well. So why again total liquid ventilation came into effect? So after initial few decades of studies with partial liquid ventilation, so they have observed more and more incidences of volute trauma and barotrauma through that. So as long as the baby is on liquid ventilation, she is fine, oxygenation improved and everything. But weaning from the liquid ventilation, again turning into conventional ventilation, and later on most of the kids used to die again. So then the scientists again now thought of total liquid ventilation, where the complete, even the tidal volume in and out is through liquid only, perfluorocarbon liquid. So this, but unfortunately, this total liquid ventilation is still in experimental phase, and it's like the latest evidence what we have is it cannot be carried out more than 4 hours. This is still the recent times. So then this article published in Elsevier, it was accepted in 2019 August. So these guys have actually explored a new paradigm for lung conservative total liquid ventilation. So they have seen why this PLV is failing or TLV is failing, and we are not able to continue. And they came to a consensus that so actually it is the if we keep down the total liquid, that is perfluorocarbon, transfused to below the functional residual capacity, which is generally around 30 ml per kg for most of us. So FRC is nothing but residual volume plus expiratory reserve volume. So if we keep the total amount of liquid transfused to below the FRC, actually they have seen better results even with total liquid ventilation and for prolonged period. Also, they have done using various volumes and all, like tidal volume. They changed low tidal volume, high tidal volume, low expiratory volume, high expiratory volume, low PEEP, and low PEEP means PEEP 0 and PEEP 5. Like this, in different settings they have tried. And this study they have also carried out using piglets, that is small pigs which weighs hardly 15 to 20 kgs, and then adult pigs, heavy ones which weigh around 80 to 90 kgs. And also there is non-human primates. They carried out experiments on 10 and 13 kg, 10 and 13 years fully grown, I mean like lung maturity is complete for the monkeys, non-human primates they have carried out. So even the monkeys, actually non-human primates fared very well with total liquid ventilation using this concept of infusion below the functional residual capacity, is according to this study. So they say that when you take care of this, and they have upgraded the technology too. So they have developed this automatized total liquid ventilator where it adjusts according to the person weight and all, and also the added incremental doses also, it will actually exactly calculated based on this new technology. So being it is below the FRC and also being dense, so the liquid actually settles down below. So even in this study, when the liquid volume is kept below FRC, so they actually have de-recruited alveoli above, I mean in the upper lobe. So that will actually allow for incremental doses of total liquid ventilation if the parameters are not being met. So this is this landmark study presented in Elsevier Medical Journal in 2019, and it adds promise to the future studies and all. So this is another advantage of this total liquid ventilation, where they have studied. This is even present in that Elsevier journal. This is published in Annals of Intensive Care. So where they have actually noticed the compared conventional hypothermic techniques what we follow in a post cardiac arrest patient, and also with liquid ventilation. So they say that generally with the conventional all the techniques we have now, so it takes at least 3 to 4 hours for cooling of the body. But with when it is done TLV with perfluorocarbons, they say that hypothermia of 33 degrees centigrade is achieved within less than 30 minutes with a very uniform hypothermia throughout the body. So it's not even, they say the brain is also not spared. Entire body, every part of tissue is cooled within 30 minutes with the TLV. So that is with TLV. So before we jump on to our Ropican, so the advantages and cons, like some few advantages are obviously improvement in oxygenation in acute lung injury. So because in acute lung, as we have discussed, the PFC surgeons, they come down and act as a positive and expiratory pressure and open up the atelectatic alveoli. Also, there will be improvement in lung compliance, and there will be anti-inflammatory effect of perfluorocarbons. And you can use this as an alveolar and endobronchial lavage. So with TLV, total liquid ventilation, you can actually the exudates also will come out along with the perfluorocarbon lavage. So what about the various studies that have been taken place over the years? So the experimental animals, non-human primates, and piglets, other animals, all these have done. What about the human studies? So the first proper clinical trial of liquid ventilation, though the most of the human trials were with more, I mean, like all the human trials with partial liquid ventilation, only total liquid ventilation, they are not done till now. So the partial liquid ventilation, the first study was in Pennsylvania in 1989, where they had a near-death infants. They were enrolled to the study, and they have tried this partial liquid ventilation there. So there was an improvement in the oxygenation and parameters, and there is more and more alveolar, the gas exchange improved, lung compliance improved, everything. So, but in this study, so after switching back to conventional ventilation, so eventually all the infants who were enrolled for the study were dead. There anyhow, they are in all these studies, the predictive mortality for all these infants is definitely they are going to die. Those kind of babies were actually taken up for this partial liquid ventilation. So all the infants actually enrolled for this study eventually died. So next study with a somewhat positive outcome came in 1996, where Leach et al. They have studied on preterm infants. So when this liquid ventilation is carried out in preterm infants, they were able to maintain it for 76 hours of this partial liquid ventilation, and they have got at least 50% success rate in this study. And also there have been multiple studies thereafter in infants, both preterm and term infants, and they're able to identify that actually preterm infants with some sort of respiratory problem have actually fared well compared to the sick term infant. So with liquid ventilation, the preterm infants are the one who are benefited more. So, and there was actually Hirschel and colleagues have done in adult cases. So 10 adults who have got a severe ARDS and not responding to any of our conventional treatment, who had repeated surfactant therapy also, they were tried with partial liquid ventilation. And in this study too, in the adult population of 10 adults, 5 patients survived for this one. So, but again, those who were survived are mostly under the 55 years age group. More than 65 years age group, most of them had met mortality. So, what are the actual, all this looks good, or at least to some extent promising, consider this a new technology and all. So the adverse effects being pneumothorax, mostly with the high tidal volume PLVs and all, and circulatory impairment, hemodynamic instability is reported. So lactic acidosis is there, one of the complications, even though the circulation is well maintained during liquid ventilation. And metabolic acidosis have been reported in various studies, and a blockage of endotracheal tube, which these are all the common practical problems we have. And carbon dioxide elimination is not so satisfactory with liquid ventilation compared to conventional ventilation. And toxicity. So even though PFCs are very less toxic compared to silicone oils, actually there is toxicity reported even with PFC, but most of the studies actually supported for PFC because the blood clearance and all is blood levels of PFC, residual PFCs is very less, and also tissues also uptake is very less with PFCs according to most of the study, but still toxicity exists. And the least uptake is by liver, and the highest uptake is when they measured few hours after cessation of liquid ventilation, the highest level was found in lungs, followed by fat. So again, as this content flow, bromide and iodide ions, the imaging actually interference with radiographic imaging is another hindrance when we are doing with liquid ventilation. So that's it. What I could achieve with before we jump on to hyperbaric roof again, which is a small topic actually. Just I need to know the inputs from people who are practicing more and more critical care and knowledge, senior persons who have heard about this one and
Can I speak?
sir, sure sir.
Srikanth, can I speak for a minute? Hello.
Sir, carry on, sir.
Okay, thanks. And if anybody else is not there, let them speak. Otherwise, I thought I'll just speak because already only 8:38. So if somebody else is speaking, let them speak first. I think as no one is speaking, what I want to ask. It's okay. What I want to ask is that presently, is there any study going on anywhere in the world at this point of time regarding this liquid ventilation?
No idea, sir. Actually, we'll find out. So the latest article I could find is this 2019 one. But I will just search again, sir. Any current studies going on?
No, the issue, what I'm thinking is because first point, as you said, within 3 hours, within 13 minutes, you're going to have a 3 degrees fall in the centigrade.
Yes, sir.
Overall body temperature, there's a fall in 3 degrees centigrade within 13 minutes, as you told in the previous.
Yes, sir.
So that is one of the dangerous thing, particularly when you have a very sudden severe hypothermia in the body. The second thing, what I'm thinking is, as you said, carbon dioxide is difficult to achieve and the acidosis is more. And nowadays, because of, I feel, more comfort have been reached by the ECMO. Because this, because advanced, the concept itself, because of ARDS, lung stress and strain pattern of the lung is going to damage more. So for that reason, the ECMO is going to keep the lung at rest. So that is another reason. Maybe I'm thinking, I don't know. That's what I'm telling you. This is only my logical thinking of what I can understand, because I don't know much about liquid ventilation. Somebody is talking.
Maybe just while joining, they have one.
Yeah. So, and because of this ECMO, and that has been gone little behind is my feeling. And because of the complications and robust mechanism, and another thing is that, as you said, everything early is always better to start, but there's no way we can do start early liquid ventilation because ethical committee permissions, ethicality has not given, even if in your studies, very end of life where you cannot do anything more, only those people were included, like, infants, as you said rightly, 55 years of age, less people only got survived, 65 they have not given. So these kind of things are there. Even other ways of liquid ventilation they would have survived, we don't know, because you cannot randomize these type of cases. So that may be the reason. These are the 4-5 points I thought I'll just talk to you, because one is the temperature, second is as you said, carbon dioxide, third is acidosis, and fourth is a recruitment criteria, because and the ethical committee permissions, all these things have been very tough for this liquid ventilation. And present advancement and technology and use of what do you call ECMO has been taken over is my feeling. But it was very nice presentation. You have given all the points, whatever is required for liquid ventilation. Thank you very much, Srikanth.
Thank you. It's actually future we may see TLB before below FRC workouts. I have to see that. All this maybe Chaitanya, all these people will be there to see the advancements.
Yeah.
Kiran, any thoughts?
No thoughts, Srikanth.
Okay, అయితే నీ ఫేవరెట్ టాపిక్ నెక్స్ట్ ప్రెజెంట్ చేస్తున్నా. Able to see my screen again?
Srikanth.
Yeah. So this hyperbaric ropecaine, how many are using now? So it's proper anesthesia topic. I need more Chaitanya, Kiran. How many are using spinal ampule recently? I think Neon guys have come to us, 0.75 ropecaine and hyperbaric one. And I mean, like remaining companies, whether they have made or not, no idea. But we are currently using this Neon hyperbaric ropecaine. So any experience, thoughts on this one? Kiran, వాడుతున్నారా ఏమైనా?
Srikanth, 1 minute.
Yeah. Okay. Carry on. So Chaitanya or anyone, Ram Prasad sir, so you're using anyone this hyperbaric ropecaine for spinal? Sir?
వెనకిల్ వాళ్ళు ఎవరు ఉన్నారా? వెనకిల్ గాజువాక ఎవరు వాడుతున్నారా?
గాజువాక కూడా చేయడం రామ్ ప్రసాద్ సార్ చెప్పాలి సార్.
సార్ మేము 0.2% 0.5% వాడుతున్నాం.
అవి ఐసోబారిక్ కదా సార్?
ఐసోబారిక్ అదే సార్.
సో okay, so we have roughly I mean like proper study laga ala em cheyaledu, actually planning to start. Actually Neon guys have come and asked me to like a format could ichcharu gaani after it recently koncham ICU busy ayindi, so I was more preoccupied with the ICU and all over the last 15-20 days, so couldn't carry out the test procedure. Actually I will share, will ask Neon guys to share that test procedure also. I mean like
always when you present also multi center study chesthe nik chaala value untadi, publication easy avutadi. Oka modu center
so that's what I will ask them to get the actually ఇచ్చారు సార్ మనోజ్ యాప్ అక్కడ పడేసారు ఓటీలో ఉంది. వాళ్ళు సెంట్ అరౌండ్ 10 copies like that, కావాలంటే జెరాక్స్ తీసి ఇస్తాం సార్ ఇంకా అని చెప్పి అన్నారు. So we have done around almost like 40 to 50 cases there. So most of the times like mundunna inhibition karanangane we have done more for abdominal surgeries and all. So first of all, before going into what the scientific literature say, the small personal experience mun cheptanu. So what I have personally onkar ochunte bond tanu kon cases chesad, but what I have personally
phone cheyi జాయిన్ అవ్వమని ఫోన్ చేయి.
కేసెస్ లో ఉన్నాడేమో సార్, ఐ విల్ కాల్ హిమ్. సో వాట్ ఐ పర్సనలీ అబ్జర్వ్డ్ ఈస్ a little bit faster onset than bupivacaine, conventional bupivacaine what we are using, hyperbaric bupivacaine. Chala fast ga undi. I mean like the studies they have comparable onset times and maintenance, sensory blockade, motor blockade ichchadu. But what I have observed is a faster onset time with this hyperbaric ropecaine compared to bupivacaine, and obviously compared to the previous spinal ampule what we used to give with the 0.75 isobaric ropecaine. Actually we used to give in our post graduation, sir Kiran and me, both of us know, used to give then with isobaric. So the problem, we used to have very good blockade for abdominal surgeries and all, but we have to wait for a little bit more time. Also the motor blockade is very less with ropecaine. So abdominal surgeries most of the times it used to be sufficient, and but ortho surgeries we didn't give at that time. So now it came with hyperbaric, so I tried for two cases actually. One DHS I have given, and another one yesterday PFN femur nail removal, implant removal was very smooth. DHS also I confirmed with the orthopedician, the relaxation and all were fair enough, almost like he didn't feel any practical difference, but like we have to see for more different types of orthopedic surgeries where they require more relaxation and all with hyperbaric ropecaine. And also these as mentioned in the studies also, this return to ambulance and return to micturition, normal micturition, all these are very good with ropecan. Actually, for short, I mean, like less than most of the surgeries don't last more than 3 hours. Less than 3 hours, it's fair enough time for even for ropecan, in my opinion. So this actually lasted good enough for 2.5 hours like that, even the motor blockade. So what we have done till now. So why this actually ropecan, how it came into existence? So bupivacaine, we all know, so the cardiotoxicity, then they search for alternatives. So the levobupivacaine and this S-enantiomer ropecan came into existence because of the cardiotoxicity and the reported cardiac arrest cases of with bupivacaine spinal. So ropecan is the S-enantiomer. So what we are targeting when we are giving spinal anesthesia, so there are the myelinated motor fibers, and A delta and C fibers are the sensory fibers we all know with the pain and all. So the A delta and C fibers are unmyelinated fibers. So practically any drug can pierce them and go through them, unmyelinated fibers. So the sensory blockade actually doesn't differ much. So ropecan doesn't cause a more sensory blockade, it actually causes a differential blockade. So motor blockade is less. So that is why we attribute it to more sensory blockade, but causes the similar sensory blockade to bupivacaine, but the motor blockade is less. Why the motor blockade is less? Because of this less lipophilicity of the S-enantiomer. So, and also its stereoselectivity, both these factors contribute to less lipophilicity of ropecan. So because of this less lipophilicity, its penetration into the myelinated motor fibers is less. So which is why the motor blockade is less with ropecan when compared to bupivacaine. And again, so all these previous studies, so why this concept of hyperbaric ropecan came into process, I mean, like studies done and all. So one, hyperbaricity will ensure a more uniform spread. Also, okay. So when we add, so how we actually before the commercial preparation, some actually try to add dextrose to the isobaric ropecan and carry out some studies, but now this commercial preparation is available. So when we add dextrose, the density of the solution increases, and it actually ensures a gravity dependent and a smooth subarachnoid spread of the drug. So also in the earlier studies when they have compared, so they have compared various like 0.5% ropivacaine with 0.5% bupivacaine. Most of the studies we know, we have read in PZ and also in later during our routine consultant life also, we came across most of these studies. So 0.5% bupivacaine and 0.5% ropivacaine. Also the hyperbaric ones. So spinal ampule, how it is working, isobaric compared to spinal ampule of bupivacaine, and epidural comparison, all these came. So the major inferences from this n number of studies is actually ropivacaine is when we compare about potency, so at low doses means what we are giving in spinal and epidural. So in low doses, ropivacaine is around 40% less potent than the bupivacaine at comparable doses. But again, when we are giving in large volumes, so like in peripheral nerve blockade, where we give 40 ml like that of 0.5% ropivacaine. So most of the block characteristics are actually comparable for bupivacaine and ropivacaine. And that is one thing. When at higher doses, they carry a similar. So if you're planning for a supraclavicular block, practically you won't see a difference between ropivacaine and bupivacaine. And when it comes to spinal, again, hyperbaric one, so this 0.75% concept came because when they carried out comparison of dosage studies, so they have observed that when 1:1 dosage, like 5 mg of ropivacaine, 5 mg of bupivacaine, 10 mg of ropivacaine, 10 mg of bupivacaine was done, this difference in potency of ropivacaine was there. But when they have done with 1:1.5, like for every 1 mg of bupivacaine, they compare to 1.5 mg of ropivacaine. Then they have found that the block characteristics like motor blockade, sensory blockade, weaning, all these characteristics what we see for spinal anesthesia, they are actually similar. So this is a beautiful review article published in JAVO ACP, that is Journal of Anesthesia Clinical Pharmacology. So this is an Indian article. So I mean, like most of the studies, like good-looking studies, are from India itself. We don't have to depend for local anesthetics on foreign studies. So this is actually done with isobaric spinal anesthesia ampule, what we have used prior. So ropivacaine is a good choice for spinal anesthesia. So in this, the difficulty, what they found with isobaric one, based on the available evidence, ropivacaine may not be the local anesthetic of choice for spinal anesthesia in cases with relatively long duration. However, its faster recovery characteristics resulting in shorter duration associated with better hemodynamic profile and earlier mobilization and voiding would make it suitable for short procedures being conducted in daycare settings. So this study was essentially done because the daycare was actually improving over the past 10 years in India. So most of the surgeries are now, if you see even in a small or medium range setups like us, we are moving more towards the daycare, patient getting admitted on the same day. They are sending some 1 or 2 days before when they have come to OP. The surgeons are sending for a pre-anesthetic checkup. We are doing that, taking the pre-anesthetic consultation fee at that time and sending back the patient. And patient is coming on the day of surgery. And most of the time it is a small one or minor procedure like that. We are sending the same day, or if it is a lap and all, we are sending the next day like that. World has moved more and more towards daycare settings. So given the current scenario and the gradually or I mean to say rapidly emerging trend of more and more daycare surgeries, so this hyperbaric ropivacaine may hold more promise for us in the future, where the patient will early return to a normal voiding and early ambulation are the key aspects when we are willing to discharge the patient on the same evening or at least in the early morning next day. So this 1:1.5 dosage characteristics, when they compared, they found out similar efficacy, which is why the 0.75% hyperbaric ropivacaine actually fares well compared to the previous one what used, the 0.5% isobaric one, spinal ampule. But the only hindrance is the cost. So MRP is 108 rupees for the hyperbaric ropivacaine, where it's just 17 rupees for our bupivacaine ampule. So again, maybe that's the MRP. Not sure about what the hospital price we are getting, so I will just inquire that one also. And so that's the main hindrance for now. But as in more and more usage comes, just like bupivacaine or like practically any other drug, we can get down on the cost for the spinal ampule too. So I will speak to Neon people today, and we'll get that format for study and all, so that we can do across our Morton anesthesia group and as a multi-center study, we can carry out that one. So I will post it in the PDF. I will ask them, and PDF or Word document, whatever. I will post it in the group after speaking to the Neon guys today. So these are the various studies, Neon guy. These studies are actually given by the company ones. So a few of the studies I've already read while getting prepared for this one, and few they have added. So these are the various studies they have compared prior studies of ropivacaine. Actually, this hyperbaric ropivacaine, proper large-scale studies need to be done. So they have launched based on the previous studies where the 1:1.5 dosing is ideal, and also few of the RCTs are there. But like Monser said, multi-center studies and all these will actually help for the future generation to use and more of hyperbaric ropivacaine. Thank you. Happy Holi everyone again.
థ్యాంక్ యూ శ్రీకాంత్. అంటే మంచిది టీసీసీ ఏమైనా చేయొచ్చామా ఎవరికన్నా?
సార్ చెయ్యొచ్చు సార్, డెఫినెట్ గా హైపర్బారిక్ అవైలబిలిటీ బాగుంది, వాళ్ళు ఇస్తున్నారు. సో వీ కెన్ క్యారీ అవుట్ ఏ థీసిస్ ఆల్సో లైక్ దట్.
శేఖర్ ఉంటే శేఖర్ గానీ అనురాధ ఉన్నారు లైన్ లో.
శేఖర్
చైతన్య ఉన్నట్టుంది.
చైతన్య ఉంది సార్.
అమ్మా చైతన్య.
సార్ శేఖర్ మాట్లాడుతున్నాను.
ఓహో
శేఖర్
పేరు నాకు కనపడలేదు, వేరే నెంబర్లోను.
రవికుమార్
సార్ కేటీలో ఉన్నాం సార్ ఇద్దరు.
ఓ నో ప్రాబ్లం, నో ప్రాబ్లం. మరి డోనర్ ఒకటి రిసిపెంట్ ఒకటి కదా, ఇద్దరు కదా. ఏం లేదు, ఇది హైపర్బేరిక్ థీసిస్ ఏమైనా చేయొచ్చా?
సార్ వీఆర్ ప్లానింగ్ సార్ యాక్చువల్లీ ఫర్ secondary DA we are planning hyperbaric ropivacaine with isobaric ropivacaine.
సరే అయితే ప్రైమరీ వాడికి మాత్రం అల్ట్రాసౌండ్ గైడెడ్ తీసుకోవాలి, లేకపోతే అల్ట్రాసౌండ్ మిషన్ మనకు ఎక్కువ రాదు.
Ultrasound guided quadratus lumborum block versus ultrasound guided tab block for lower abdominal for abdominal surgeries, pain relief, post of pain relief.
అది క్రాంతి కుమార్ కా?
క్రాంతి కుమార్ సార్ అది.
వెరీ గుడ్.
ఈ రెండు ఉన్నాయి సార్, ఇంకా వాళ్ళకి ఇంకా రాలేదంట, దట్స్ వై వీఆర్ వెయిటింగ్ పంపిద్దామని. వాళ్ళు పర్సనల్ మెయిల్స్కి వస్తాయంట థీసిస్ పంపించమని.
ఈ లోపల డేటా ప్లస్ లిటరేచర్ అంతా రెడీ చేసి పెడితే బాగుంటాయి కదా.
యా నేను చెప్తాను సార్, రెడీ చేయమంటాను. ఇది దొరికేస్తుంది, రొపివకేన్ దొరికేస్తుంది, బట్ క్వాడ్రాటస్ లుంబరం కూడా దొరికేస్తుంది, నో ప్రాబ్లం. ట్యాబ్ బ్లాక్ ఎలాగో ఉంది, ఎక్కువ డేటానే ఉంది. క్వాడ్రాటస్ లుంబరం కొంచెం తక్కువ ఉంది, బట్ వీ కెన్ గెట్ ఇట్. నేను చెప్తాను.
చైతన్య దాంట్లో మాట్లాడుతున్నా,
ఇద్దరం అదే ఉన్నాం సార్, అందుకని.
థ్యాంక్ యూ శ్రీకాంత్, బాగుంది ఈరోజు టాపిక్స్.
Srikanth, hello. Can ropin can be used for ophthalmic block? We are using levobuprofen for ophthalmic block. Similarly, can we use isobaric ropin for ophthalmic block? Are there any isobaric?
Neocolin stick can be used now, sir. Actually, better hemodynamics and all with ropivacaine. Levobuprofen vaartunnaru sir ippudu. That's hyperbaric, isobaric.
Levobuprofen we are using in Vasana.
Okay.
Sir, actually, I need to share something. I did a comparative study between bupivacaine and levobuprofen and ropivacaine, isobaric and hyperbaric. That's my thesis, actually.
For blocks, ophthalmic blocks and no.
No. For spinal anesthesia. And Omkar did comparison between ropivacaine and bupivacaine for obstetric surgeries.
చెప్పండి. నేను యాక్చువల్లీ అనుకున్నప్పుడు హైపర్బారిక్ ఎక్కువ వాడలేదు తను ఇంకాను.
Hyperbaric is recently introduced by Neon actually. We did with isobaric.
Yeah. So hyperbaric ఒక 40-50 cases చేసాం కంటిన్యూస్, ఆల్మోస్ట్ లైక్ ఇప్పుడు 80-20 వచ్చాయి మేము.
బట్ బై ఆన్ హ్యాండ్స్ నేనైతే హైపర్బారిక్ వాడలేదు. బట్ హౌ ఆర్ ద హీమోడైనమిక్స్ ఆర్ బెటర్ విత్ levobuprofen in my experience.
Even with ropin అసలు మెఫ్ ముట్టుకోవాల్సిన అవసరం రావట్లేదు.
Okay.
Even the
actually the comparison between levobuprofen, bupivacaine and ropivacaine, it is like bupivacaine is most hemodynamically unstable compared to ropivacaine when compared to levobuprofen. Levobuprofen is highest stable. We never used anything for levobuprofen with good analgesia and motor block also. With ropivacaine, some sort of sensory motor block is not there. Yeah. That is there.
నీది కాపీ పేస్ట్ థీసిస్ కాదు శేఖర్, అందుకే అంత గట్టిగా గుడ్ టు వెరీ అంటున్నావు.
ఎస్ సార్, కాపీ పేస్ట్ కాదు సార్, కష్టపడి చేసిన థీసిస్ సార్.
అదే అలా చేసినప్పుడే వర్డ్స్ అలా వస్తాయి.
So now we have to see what's this new one is up to, but hemodynamics and abdominal surgeries were very comfortable, Shekhar.
Okay.
చాలా బాగుంది. యాక్చువల్ గా మంచి సర్జన్ ఫ్రెండ్లీ ఏంటంటే ఫాస్ట్ ఆన్సెట్.
ఓకే.
అసలు స్పైన్ సార్
నియానోడ్ స్పాన్సర్ చేస్తున్నాడు బాగా.
స్పాన్సర్ యాక్చువల్లీ ఇంకా వేరే కంపెనీస్ వస్తే బాగుంది సార్. వీడు వేస్ట్ ఫెయిల్ అయ్యాడు.
వీడు బేసిక్ యాక్సెస్ పెద్ద ఇబ్బంది సార్ వీడితో. ఇప్పుడు ఈ మధ్యన యాక్సెస్ దొరకట్లేదు వాడిది అసలు.
ఇదైతే యాక్చువల్ గా వేరే కంపెనీస్ వస్తే బాగుంటుంది. నియోనాట్ తో డీల్ చేయడం ఎలాగైనా తలకాయ నొప్పి. ఇప్పుడు కాబట్టి అన్ఫార్చునేట్లీ ఈస్ ద ఓన్లీ వన్ సప్లైయింగ్ దిస్ హైపర్బారిక్ వన్స్.
Yes.
రమణ ప్రసాద్ గారు అడుగుతున్నాడు.
Sir, one question for juniors. Why the cardiac arrest due to intravenous bupivacaine is refractory to treatment?
ఇంట్రావెనస్ లేకపోతే కార్డియాక్ అరెస్ట్ అవదా?
కాదు, bupivacaine తో సార్. అదే cardiac arrest due to bupivacaine.
ఓకే సార్.
హలో,
ఏం కనపడదు కదా సార్ జూమ్ లో. వెంటిలేటర్ లో తెలియదు, జూనియర్స్ అంటే ఎవరిని జూనియర్ తెలియదు.
because it binds irreversibly with the myocardial proteins.
సేమ్ క్వశ్చన్ ఇంత ముందు అడిగారు, సేమ్ ఆన్సర్ ఇంత ముందు చెప్పారు.
అవును సార్, అవును.
రోపిన్ హెవీ ఎంఆర్పి 108, హాస్పిటల్ ప్రైస్ 77 అండి సార్. బ్యూఫెకెన్ ఎంఆర్పి అండ్ హాస్పిటల్ ప్రైస్ ఆర్ సేమ్ 28 రూపీస్. 17 ఉండే సార్, తెలిసినట్టున్నారు పోస్ట్ కోవిడ్. 28 రూపీస్ బ్యూఫెకెన్, సేమ్ ఎంఆర్పి అండ్ సేమ్ హాస్పిటల్ ప్రైస్. సో హాస్పిటల్ వాళ్ళు కూడా ఎగ్జిట్ అవుతారేమో. కాస్ట్ మార్జిన్ ఉంది దీంట్లోనే, 31 రూపీస్.
శ్రీకాంత్ అలా కాదు, నీకు అసలు విషయం తెలియదు. కార్పొరేట్స్ కి సేమ్ కంపెనీ వాడే బుక్ రూపాయలు వేసి 280 రూపీస్ ప్రింట్ వేసి ఇస్తాడు కార్పొరేట్ కి అయితే.
ఈ స్పైన్ యాంపిల్ సార్ మామూలుగా
ఏదైనా సరే,
ఏదైనా
మెడికల్ షాప్ లో ఇచ్చే ఎంఆర్పి వేరు, కార్పొరేట్ లో ఇచ్చే ఎంఆర్పి వేరు. లేదు బయట నువ్వు 28 రూపీస్ అనుకో, కార్పొరేట్ కి 5 రూపాయలకి అమ్ముతాడు.
హాస్పిటల్, మన హాస్పిటల్ కి ఇస్తున్న ప్రైజెస్ చెప్పాడు సార్ ఏబిసికి. ఆ డిఫరెన్స్ కూడా ఉంటుందేమో మరి.
థ్యాంక్ యూ. రమణ ప్రసాద్ గారు, అగైన్ ఐ థింక్ ఎవ్రీబడి షుడ్ నో. కావాలంటే అది మెసేజ్ పెట్టండి ఒకటి, ఎందుకంటే అందరికి మోటార్ల గ్రూప్ లో ద ఆన్సర్ వాట్ యు గివ్ ఫర్ ద రిసెప్టర్స్ కనెక్ట్ అందరికి తెలియాలి.
Okay sir, thank you so much. Happy Holi.